I have the introduction slide. I'm sure everybody can read it, so it'll be stupid on my part to read line by line. We all do realize, reading this very extensive CV of Sister Hanife, that she is an awesome person, a wonderful nurse who has worked all over the world, is advisor or honorary instructor to many organizations like ELNEC or DIPNIP Care, or for that matters, the Trinita Society for Children, Social and Health Research in Kolkata. Uh, Most importantly, she has been in India for over 25 years and has started outpatient clinics and volunteers as a home care and OPD nurse. Now, her subject today is on ostomies. And I think that, we take these things for granted at this point of time. But I remember many years ago when I worked in Tata Memorial, that we came to know of the story of a gentleman. I can't remember his name. If I'm not mistaken, it is some Kapoor, but I may be mistaken, who went to an oncology center in the US where he had to have a colostomy, and he was so impressed by the way he was counseled, how an ostomy nurse came the previous day, literally marked out where the stoma has to be placed, and he came back to India, and the Ostomy Association was formed in 1975. And I'm sure that we will learn a lot of very practical things from Sister Hanife. It's a very important thing, even for palliative care people, because we have to manage these stomas, and it would be wonderful to get some practical tips from her. So thank you very much, Sister Hanife. Very grateful to you for being part of this morning session. And I request you now to take it away and please enlighten us on ostomy care. Sister, please, you can start your presentation.
Well, very good morning. Very good morning to you. And thank you for my introduction. And I'm going to try my very best to share my slide. Ostomy care is very important for nurses, for the patients. It's a whole different ball game in different parts of the world. And I change ostomies a lot. I work with ostomy patients a lot, but honestly, I haven't taught ostomies for a very long time. And so today I thought we should talk about a different side of ostomy care. How do we manage the person who is wearing that ostomy? Sure, I will tell you some practical things, some do's and don'ts, but I also want to talk about the things that we really don't talk about, that we need to talk about. So let's see how this is going to go, and I hope we have a conversation about this. And I hope in many ostomy clinics, the nurses will pick up the pieces and they can really assess the quality of life of the ostomy patients. This is really important, especially in palliative care when there is a double burden. There is a double burden. Okay, next, please. So, ostomy, like all the wounds in palliative care, actually in all care, it should be an interpersonal, patient-centered approach. It should alleviate the suffering, promote the well-being, and promote a quality of life. Next. Next. So there's the ileostomy. Back, please. There's the ileostomy, which is the surgical opening constructed to bring the end of the ileum, loop of ileum, out on the surface of the skin to allow the feces to leave the body without passing through the large bowel. Now, if we go through for colostomy, it is when the healthy end of the large intestine or the colon is brought out through the abdominal wall. So the feces leave the body without passing through anus. Now the urostomy diverts the urine from the normal route, and this is necessary when the bladder is removed or bypassed. Next, please. Next. So colon and rectal or bladder cancers, inflammatory bowel disease, trauma, congenital disorders, diverticular disease, neurogenic bladder, which cannot be managed otherwise, will need stomas. Next. I like to talk about urostomy because we always talk about colostomy. And what is urostomy? And I also think that it's really, when I was at school, I thought this was really some magic they did. So in the urostomies, ileocondia is most common. It's usually on the right side of the abdomen. And what happens is that they take a part of ileum, they cut it up, they attach the intestines back together, and they function just fine. Now, the piece they sew the other end, and the stoma comes out and it's folded over and makes a stoma, which means the mouth, right? Bypasses the bladder, or the bladder is removed, or it's still there, but it's not in use. But with this, a pouch must be worn at all times because it's a incontinent ostomy, of course, and urine will always come out. So, and this sleeve that comes out, it is sewn to the skin. Next, please. So, on the left, there is the stoma, which is swollen, larger than it will be when it heals. This is after surgery. On the right, it's the good old stoma, soft and moist, pinkish and red, round, and the skin is also normal. When stoma is white, it might bleed because there are tiny, tiny vessels and are very close to the surface. Stoma usually protrudes slightly from the abdomen. Next. Next one. Next. This is the ostomy triangle. We want the ostomy on the abdominal muscles, if it is at all possible. So it will be on the transverse colon, on the descending colon, and also it will be in jejunum, and it can also be, as we said, the ileostomy and the urostomy. Next. So it is very important that the colostomy or the stoma site is marked properly. Now, selection of the site in collaboration with an ostomy nurse specialist or somebody who's going to take care of this patient afterwards, and the surgeon and the patient is necessary. The site marking should be performed by a trained ostomy nurse. Next, and we need to put a clear tape over the marking and send the patient off. There are many things that we need to consider. We'll come to that. But the preoperative stoma site marking usually builds a close relationship between the patient and the stoma therapy nurse. And then when we do take care of these patients, we have already built some kind of trust. We have some kind of bonding. If the ostomy is poorly located, then it will need diligent, constant monitoring to avoid leakage, embarrassing accidents, which participants found emotionally exhausted and stressful. So I think here in India, it's mostly the doctors and the nurses do it together. The nurses do not do it alone. And I think that's a good practice. So what we consider is the abdominal wall shape, both sitting and standing, prior abdominal incisions, bony prominences. What is this person doing for a living? What is his or her clothing style? Her disabilities and physical limitations? Is he or she obese? Is she or he wheelchair bound? Has ventral hernia? Does he have multiple stomas? Is there a history of prior stoma? What is the lifestyle? We have to make the patient sit. We have to maybe lie down and raise their head and find the muscles that are in this triangle down below by the pubic area. But we need to spend a lot of time and a lot of listening before we say, okay, this is the right place for this person to have the ostomy. Because once it's done, then correcting is a lot more difficult. Next. So this is cut and paste. Which pouch? The type, the size, and location of the stoma will tell us which pouch. Abdominal size and contour will tell us which pouch. Peristomal skin conditions, physical and mental status, physical activity, the cost, how much does it cost? A lot of money. There are many different kinds of stomas, colostomy bags right now. But the price is exuberant, even when they go to the colostomy clinics. There are many people I see day in and day out, walking in Delhi with a garbage bag. And it's really sad. But anyway, patient, what does the patient prefer? Local availability, nature of the output, and the sensitivity. And of course, as we will talk a little bit later, the dexterity is of an issue. How is this patient going to deal with the clamp? Is the Velcro at the bottom better? Is it better, really expensive, but better to have a disposable pouch than trying to teach some little lady how to wash the stomach? When there is no caregiver, is she going to sit with it full because she cannot change? We got to think about these things. Now, not only the pouch, but there is also a thought about a belt. Is this pouch going to have a belt? Now, normally colostomy bags have two flanges on the sides where you can put the Velcro bag, belt and tie it on the back. Now, it looks fine, it holds it in place, but we never think that it really hurts the back. It makes an indent. It kind of, in the heat, the plastic buckle makes you sweat. We need to think about that. And maybe sometimes it's best to kind of sew it and keep observing it so that it's only in the front that it attaches, and the back attachment is kind of elastic, but it needs monitoring. So we need to think all the time. Next. So the best time in the morning is when people are asked to empty these pouches. They are supposed to empty them when they are 1/3 full, but they have to remember that the stomas may be functioning during this time. So we have to teach them how to be prepared, because the feces might be coming out. Urostomy urine will keep dribbling. So maybe a rolled up towel, maybe a container, maybe newspapers, maybe if they are able and willing and strong, maybe really standing over the toilet or a basin. These things we have to consider. Next. So we irrigate to regulate bowel movements. We also we irrigate to help avoid constipation. There is one thing that the nurses do not do. They do not mark the time of irrigation, solution and the amount used, the dressing applied, condition of the area, color, amount, and consistency of the return. And for me, the most important, how is the patient reacting to the procedure? Is he or she participating in this? Or is she turning her head? Is she able to clamp and unclamp the water? These things have to be noted because they all impact her quality of life. Next. So there are foods to avoid: the egg, the fish, the garlic, onion, cabbage, cauliflower. We tell them these things. And also, next, there are foods that will harden the stool, like the banana, the buttermilk, the cheese, the boiled milk, noodles, yogurt, and rice. Basically, this is like the brat diet we give to people when they have diarrhea. Soluble, water-soluble fiber is necessary. But if they are, if we keep telling them eat fiber, what fiber? Psyllium is good. But there are other fibers that is only going to make them bloat because they're not water soluble. So we need to think. Next. So, of course, obviously, they are going to be taught how to avoid the foods that upset the stomach, and dry fruit, peas and nuts and coconut and all these things they have to be careful about. As we said, yogurt and buttermilk are good. They should not add aspirin to the pouch to get rid of the smell. And even aspirin can help prevent the odor. It could cause ulcers on the stomach, and we don't need aspirin in a pouch. Urostomy pouches are pretty odor resistant. They don't permeate. And also some other pouches have the vents, and they have carbon filters. There are many, many ways besides putting aspirin in the pouch. And sometimes we put drops of neem essence, and that really works very nicely. We put lavender essence sometimes just to make them feel good. And sometimes the stomach care becomes like giving oxygen to a dying person because the family wants it so. You know, so we go with the flow within reason, but aspirin in the pouch is not okay. Next. So we need to tell them to chew well, introduce the food one at a time, small frequent meals, a cup of tea. Walking is a very good thing, clears their mind, helps the ostomy, digest the food. They should not skip meals. They should avoid carbonated drinks at all costs. They should not chew gum, and they should not use straws so that the air, extra air, doesn't come. Okay, next. When they are traveling, they need to carry spares in their hand luggage as well, in case the luggage is lost. And also, there is also a problem that the bag might explode. We should tell them this gently, because if you carry an umbrella, it's not going to rain, usually. If you don't have one, it's going to pour. So we tell them we want to be precautious. It's not going to happen. They might need to carry a special certificate for carrying pouches and spares in this day and age, especially if they are traveling by airplane. If it's a long journey, it's best to irrigate the pouch just before leaving, and then again when they arrive. And if the tap water is not drinkable to you, then it's not good for your ostomy. So it should not be used for irrigation. And what do? We need to make sure that we have talked to an ostomy nurse at the destination. And maybe if they are driving a long way, maybe we need to connect with somebody in the middle so that it's covered, so there's peace of mind. I will tell you the story about this later, but this is essential. So we've done something, we've organized. It's not enough to say, carry a spare, irrigate, have a good time. We need to do our part. We need to give a phone number with the phone that you are going to answer. Call me if there is any issues, but there is a nurse, a clinic in this place, in that place. And it would be best if you could have a dialogue with these people before the trip happens. Next. So with urostomy, with colostomy, there are many things that we need to teach the patient beside the food they eat. Change the pouch regularly, prevent the pouch leaks, empty the pouch when it's 1/3 or half full, check the pouch for pinholes, cleanse your night drainage bottle if it's a urostomy, and tubing and adapter daily with warm soapy water, because the urostomy needs to be attached to a bedside bag at night. We need to tell them that. We use vinegar and water solution 3:1, and we ask them to hang it to dry. We also tell them that usually urostomy, the urine will contain mucus shreds, and the mucus is more in the beginning after surgery, and it's going to be less. If they are taking medicine, and if they have a urostomy or a ileostomy, they should watch if the medication is coming out, if there is any medication pieces or any undigested medicine in the pouch. They need to drink 8 to 10 cups of water because they are losing a lot of water. Now, cranberry juice, to keep things in balance, is one thought. Now cranberry juice is available, but I really like to give them neem water, and they like that because most people, including me actually, think that neem is good for anything. When I first came here to Kent Support, me and nurses would talk. We were all old nurses, and we would just say neem for this, neem for that, neem for that. And actually it's true. Jamun is good, jamun is good, jamun water is good. And also what is really good is pomegranate juice. Pomegranate juice is a problem because pure pomegranate juice is extremely expensive. And the other pomegranate juice, I think, does more harm than any good because it's full of sugar. So they can eat pomegranate, but it has too many seeds. And that may not be the right thing to do. So there is a dilemma there. Vitamin C to keep the urine acidic with the urostomy is also debatable. It's best to eat the vitamin C, oranges and whatever. But of course, there's always a problem in India with oranges. It's cold. The weather is cold. I won't eat an orange. When the weather is hot, the oranges that come out in the hot weather are very hard to peel. They don't always have a knife handy, so they don't eat. So there are these things that we need to consider. Think about how we can go about it, how we can help them out. Next. Next. So after the life after surgery, they should consume their activities as usual, within reason. Strenuous activities such as lifting, vacuuming, bending profusely, especially for tall people. At least this should happen after 6 to 8 weeks. Vacuuming is not an issue here in India as much, but there are patients who have vacuum cleaners. And it's just like after C-section. It's not good for the ostomy site, for the ostomy bag, for the ostomy stoma to heal, but it also vibrates your inside funny. So they get a funny sensation. Now, I think today, maybe there are a few nurses, there are many doctors. We really, truly have to talk about intimacy. Intimacy, the nurse should make sure that at least patient discusses this issue with his or her partner. And also, if it's a male nurse, maybe the male nurse can talk to the husband separately. A female nurse could talk to the patient separately. Maybe everybody can have a family conference. This is part of their lives. Some of them are young, even when they are palliative care patients. They are cancer patients. This is a big problem. There is this bag that sticks out that reminds you of your illness. It reminds you that you are really dying. The smell of a urostomy, colostomy, is double-edged sword for a palliative care patient. Any smell, yes, it makes them nauseous, but it also makes them think, I'm rotting, this is bad, especially with the wounds. With the colostomies, they don't like to look at these things. You know, so sexual activity may resume if the doctor says it's okay, and when the patient is physically and emotionally ready. It takes time to adjust. If the bladder was removed, some nerves controlling the sexual function may be damaged in men, and they might have difficulty with erection and ejaculation. We need to tell them this. Emptying the pouch prior to sexual activity. Covering the pouch with a pouch cover. Pouch cover is like a cover, it's like a table cover with elastic around, and you just put it over the pouch. Or maybe we can tell them to wear some fancy lingerie for women. And the best thing to do for man and woman, if you cut the crotch, you know, the front and the back joint in the crotch, if you cut that, it becomes like an abdominal binder, but just the right size, width-wise. And it covers the ostomy. And also, we will tell them, don't use transparent bag. Little things. And they can be always intimate. There are many ways of showing care and love to a partner, but also they can try different positions that are comfortable. If the colostomy is on the left, maybe they can lie on the left side. They don't see the colostomy. And also it's secure, it's not moving around. Abdominal binders make good bags, good belts. Because if it is fitted to the body, we can buy nice ones for about 450, 500 rupees. But these are the ones that do not have a Velcro, which is good because it's better for the other person. Little things. We need to tell them that. We need to tell them that it is the same person. But of course, with teenagers, this is a very big issue, my body image. If somebody has a new partner, this is also a very big problem. Of course, there are husbands and wives who are willingly taking care of the ostomies of their husbands and wives. And they don't mind having a sexual activity with this person. But we need to cover all angles because everybody who has a colostomy is not married to an understanding, kind husband who loves the partner regardless. This is one less problem because it is an issue. And, there is a book from the Ostomy Association of India. It's really a nice book. It's called Renewal of Life. And at least it talks about it. The love doesn't go away. Love conquers. Love is good. But love is like compassion. Sometimes it needs action. No. And how are they going to do this action? The nurses don't talk about it. The doctors don't talk about it. The colostomy, ostomy clinics don't talk about it. The patient is too shy to go to the father-in-law, mother-in-law, sister-in-law. They are just going to sit on this. And if you don't vent something, we all know what happens. Things explode. So we need to really, truly, honestly address this issue. Doctors can have nurses with them, talk about it. Nurses can talk to the patients alone once you have the good trust. You can follow up. You can help them. We are all women. Male nurses can talk to the male ones. They're all men. I think we need to get over this taboo and talk. Dr. Shushma always tells this story about a patient when they were talking and they had built trust and they had a relationship. And when she came out to talk to her, this was for, I think, a block or a pain management or something. Patient was so happy to be going home, and her pain that was going on and on kind of disappeared. And she asked Dr. Shushma, "Can I have sex with my husband?" Wow, this is liberation for the doctor. When my patients hug me and say thank you, this is one more thing we've done for these people. So let's think about it. And for colostomy patients, they can irrigate before. They can put a nice dressing on it. They can talk to their partners before. And they can have some nice intimate time. We are all in this field. Body is not a taboo, and we should start talking about it. 50% of the women that I see home care who are palliative care patients, but who are not imminently dying, are worried about their colostomy, urostomy, because of their partners. So we can help. Next. Next, please. Okay, so we need to do an impeccable assessment. We need to, you see, when patients come to us, especially in a palliative care setting, even if they were just plain good old oncology patients, do they have motor and sensory deficits? Do they have enough dexterity, like I mentioned earlier? Can they really do these things? Can they change? Maybe two-piece ostomy is better than one piece. Can they open the Velcro, or are they going to clamp it? Can they really empty this bag? The vision deficit. Are they able to see? Now they make these bags that you don't have to use scissors. You can put your finger in the hole and expand it. It's this mushy foam-like thing. It's available in India. They are using it at Ames, but it costs arm and a leg. Until that becomes cheap, people still will have to cut the right hole. Yes, there are caregivers, and we need to talk to the caregivers. But we also have to think about these people who need to have independence, who have to have their autonomy at one point or another if there are no other reasons for that, to lose the autonomy. So, and cognitive deficiency, do they understand? You know, in America, when we worked as ostomy wound nurses, and like any other nurses, you always have to begin to think. You want to think like the patient. You want to bring yourself to this patient's level. If they are too high up, then it's more difficult than they are your average Joe. But you need to think like them. This is the extension of your empathy. And then with all these urostomies and colostomies and all these things, there are going to be many complications like blockages and all these things. I think it is more useful and beneficial when there is hands-on care, like we try to do very frequently, about how to measure the ostomy bag, how to attach the ostomy bag. Of course, the site has to be cleaned with soap and water. It needs to be dried nicely. It needs to be aired. Skin has to be assessed, and it has to be charted. There needs to be a standardized charting that everybody really fills out. And the ostomy nurses, the ostomy clinics should have quality of life studies done. And in order to make them realistic, everybody should chart the same way. Well, of course, one of the answers for that is ticking the box. But we all know what happens when people have a box to tick. They tick the box. And I think in more ways than one, we should start thinking out of the box. So there are going to be changes in the abdominal plane. There is a very nice article from the Journal of Palliative Care in India. And this is actually the work they did in Jodhpur at the wound clinic, which also does palliative care counseling. And the patient had had many surgeries. This wasn't really for urostomy, but they used the bag. And how do you attach the bag when there are so many creases, so many scars, so many problems on the abdominal surface? Or when the weight, and they use colloidal tape over the stoma, and they fill the gaps with tapes, and they made a surface. Actually, they recreated a surface. It was very nice work. And but also people are going to lose weight. They are going to have ascites. How are we going to deal with these things? And the thing is that when there are wound rooms, wound changing, dressing quarters in the hospitals, normally, like in Rajasthan, in Gujarat, and many places in Bihar, that I know for sure, that instead of nurses doing these things, they take these patients to the wound changing, wound dressing room. This is not a disease. And I couldn't find the picture, but I have a photo of like 6 nurses standing by the patient on the stretcher, waiting for a doctor to come and change a colostomy bag. This is disgraceful. This is a nursing job. And when we do so if we change the dressing, we have time to talk to the patient. We have time to let her vent, but we also have time to really assess, to see what's going on, and apply whatever we need to apply to make sure the skin is clean. And we do our job. Emptying a colostomy is a nursing job. Changing a colostomy is a nursing job. We need to understand that. And I think the doctors should, you see, I'm just jumping here for a little bit, but when I first came here, it was actually in 1992, I was working with Ken Support. And they said to me, why don't you go and give a talk on the nursing issues in palliative care to this one nursing university? I said, okay. So I picked up my slides and I went. And I talked about grief, bereavement, exhaustion, moral distress, and self-care. And the nurses saying, "What? This is great, but this is not a nursing issue." How can it be not a nursing issue? We are very able to talk about these and a lot more, but we are always told wound care, ostomy care. It's time to think out of the box. And we are learning so much ostomy care that we are missing the boat on the other side, and we are not even doing the ostomy care properly. We need to find a way. And this is what I've been trying and I'm working on. And as I go from one hospital to another, one city to another, and meet with all the nurses, we need to find a happy way. Anyway, so the abdominal planes will change. We might have to use tape. We might have to adjust. We might have to do many things in order to make sure the colostomy bag is sealed and comfortable. Belt can be useful. There is a belt that goes around, as you all know, and it has a hole in the middle that the colostomy bag can come out. Now, this bag is good because it keeps everything in place. Abdominal binder with the Velcro that closes over the bag, as long as it's not very tight, it's also very good to keep the colostomy in place. But we need to observe, we need to check. Now, mucocutaneous separation can happen especially if people are on corticosteroids and if they are smoking. And this is going to happen very rarely, but it will happen. If that does happen, we need to do proper wound care and irrigate the wound with normal saline, and then apply the bag with a barrier underneath and check the skin and document. We need to document properly. The peristomal varices are going to happen around the stomach because there are these tiny, tiny little veins and capillaries. The color will turn purplish. We need assurance to the caregiver. We need assurance to the patient. And we need to kind of observe it and see. And we also have to teach them how to remove them properly. People who have liver issues, they are going to have these varices. And the peristomal moisture is going to cause dermatitis. This is a big, big problem because the bags are not changed when they should, number one. Caregivers are in a hurry at home, number two. Nurses are not observing properly, number three. They don't have good hygiene practice, number four. Many reasons. But when it happens, it can be very uncomfortable. It can be itchy. With the children, sometimes it can be so bad that I have to put lidocaine cream around here so we can touch the ostomy. And it's very sad. And we do something that we call the crusting. We put the barrier film and then we put the powder and we make a crust. Okay, and we can do that. But we need to keep watching. We need so much information from these people when they come to us. We are concerned about their ostomies, but we need to know their history, their likes, their dislikes, their goals of care. This is part of their treatment. This is part of their life. How does it align with the goals of care of this person, of this family? Do they understand? Nurses don't like looking at the feces. Nurses hardly ever empty urinals. The family, how much can they do this? We Let's stop for a minute and think about this. It smells, it looks, they are shy, there's self-image, there's embarrassment, there's gas, hardly ever privacy. It's time for a lot of empathy. Anyway, the wound care needs to be done on the dermatitis. Sometimes it needs its own dressing. Every time we put the colostomy back, we do the care. Please take deep breaths. Breathe from your mouth if you have to, but make sure you're not grimacing, you're not making funny faces. And oh, how horrible. Don't say how horrible it looks. It's very red. We will take care of it. We will do it. You will dry it better. I have good medicine. It will heal. Next, please. You see, just like with everything, this model is not only for the patients who are dying, who are coming to the palliative care or not dying just yet, or they're at the end of life. This is really for everybody. The physical, the psychological, the social implications, and the spiritual assessment. Why do I have this bag? Why is my inside coming out? Why can't I be like normal people? Why is God punishing me? If you talk for a long time to an ostomy patient, he or she will say, why is God punishing me? It's not only the patient who is in bed who's dying, but we need to talk. We need to open the dialogue. It's not simple. 4 elements are still there. And money, how much it's going to cost? I don't have money. The powder works really nicely, but how am I going to buy this powder? I cannot clean without a glove. I have one glove I wash and I wash and I wash. Now it has a hole there. Next. You know, I don't know if anybody knows about Dr. Naomi Raymond, but Dr. Naomi has Crohn's disease, and she has had a colostomy since she was 28 years old. 80s now, and she lectures at the University of California in San Francisco. She's a clinical instructor at the clinical professor at the medical school of University of San Francisco. And she has this article, and here it says, at first I was stunned because a woman came into her room one day, and this is a true story because I've known her for the last 30 years. And a woman came in and she didn't even put gloves. So she talks about breaking the professional procedure, but this is like 30 years ago, 40 years ago. And she was laughing and speaking with her. And she had beautiful fingernails, very nice and trimmed and clean, and a little piece of jewelry. I think she was the head nurse who was going away. They realized they hadn't changed her colostomy, so she came to do it. And when this happened, she says, I knew without the slightest doubt that I could do this. I could find a way to live with this colostomy. It was going to be okay. In 10 minutes, She not only tended my body, but healed my wounds. And what is most professional is not always what best serves and strengthens the wholeness in others. We have to take this as stride. We need to be safe, especially these days. Everybody's, we need to be triple, quadruple safe. But there is a limit. As I always say, if you are in PPE, if the patient is all gowned, what is stopping you from hugging this person? You have a shield. You have a mask. She has a shield. She has a mask. Nobody is going to cough. Just at least really hold her hand properly. Glove to glove. It's okay. It's better than no holding. Anyway, Naomi Raymond also wrote The Kitchen Table Wisdom. She's a wonderful doctor, really nice lady. Next. I'm almost done. This is from the Ostomy.
We've got just 3 minutes before 7:30, and there are some questions. So
I got one more slide.
Thank you.
One more slide.
Thank you. Go ahead, please.
Thank you.
Lovely present.
If you are among those, thank you. If you are among those who care for ostomates, make sure that lifelong supervision includes a generous portion of compassion. This is the nurse who arranged for a couple to go on a long car ride to celebrate their 50th birthday. They hired a driver. They had a great time. They visited family. 3 days after they came back, he died with his colostomy. But he managed. She arranged everything. Next. People forget what you say. They never will forget how you make them feel. We need to make them feel they are human. What do we say? Your dying patient is a living person. We have to take this one level up. Every disease has a person, and we have to see this person, whether we are doctors, whether we are nurses, and hopefully whoever else is in our team. I think this is all I have to say. This is a sore subject in my heart. And so I wanted to talk about it. And maybe somebody will do something. There was a question about what do you rinse the bags with? And to rinse the bag, I use 1-to-1 vinegar and water. I use vinegar for everything because vinegar cleans, takes care of the odor, and if it is really stubborn smell, I put a teaspoon of baking soda. Shake it nice, rinse it well with good water. And then it's okay. You know, if they say, if you are making risotto, you only use the wine that you will drink. Otherwise, your rice will not taste good. This is what we say in the West. If you're doing the colostomy, you only use drinking water. Please see the person. Don't tell them, go to this clinic. Don't tell them, go to that clinic. Talk to the people. Anyway, I think we can all do it. As I always say again, whatever I'm saying is nothing new. I just want to juggle your wonderful, brilliant brains because you all got it. But shake it and get it out and do something about it. And
thank you, sister. I'm going to put the guillotine now. Arun, anything else? Any other questions?
No, thank you very much, Sister Hanife. There are no more questions. And she answered. There was one question. She answered that. Thank you so much.
Yeah. So
thank you all.
I think apart from the technical details, which I think are very, very important, it's the approach. It is treating the person as an individual, a person with a with the soul inside, and we have learned such a lot from your experience, sister. Thank you very much. And it's been really a privilege to listen. And if any of our participants have any specific questions, they could perhaps email it to either sister or probably to the
Yes,
Iapc.
please.
Yeah, and we will.
Yes,
we will,
email or WhatsApp.
Yeah. So
Email or WhatsApp.
that will be wonderful. So if there's nothing else, I wish all of you a wonderful week ahead. Keep safe. Keep praying for the others who are suffering, and I look forward to seeing you next week. Thank you very much. God bless and take care.
Thank you very much. Thank you. Bye-bye. Thank you. Thank you very much, everyone.